Most people who get a stent placed think the hard part is over, the blockage is open, the blood is flowing, the crisis has passed, and in one sense, they are right. But here is what almost nobody tells you in that hospital room. What you do in the first 12 months after a stent determines whether you stay well or end up back in an operating room. A stent is not a cure. It is a fresh start. And what happens next is entirely up to you. I am Dr. Robert Anderson, and today, I am going to walk you through exactly what a stent does inside your body, how it works, and the specific decisions that protect it or destroy it, including one mistake that sends patients into emergency cardiac surgery weeks after their procedure. Most of them had no warning at all. Let us start with what went wrong before the stent was ever needed. Your arteries are tubes. They carry blood from your heart to every organ in your body. When they are clean and open, everything works. But over years, sometimes decades, a substance called plaque builds up on the inner wall. Plaque is a mixture of cholesterol, calcium, fat, and inflammatory tissue. It accumulates silently the way a pipe gradually furs up with mineral deposits. The medical term for this is atherosclerosis. As plaque grows, the opening inside the artery narrows. When that opening is reduced by roughly 70%, the heart muscle starts struggling to get enough blood during exertion. That produces chest tightness or pressure during physical activity. That condition is called stable angina. But here is where it can become an emergency. If the plaque ruptures, the body responds the way it always responds to a wound. It sends platelets to form a clot in a cut on your skin that is protective. Inside a coronary artery, it is a catastrophe. The clot forms on top of the ruptured plaque, and the artery closes completely. Blood stops reaching the section of heart muscle that depends on that artery. That is a heart attack. And time is everything. If the artery is reopened within 4 to 6 hours from the onset of chest pain, most heart muscle cells can be saved. If 12 hours pass with the artery still closed, most of those cells are dead. They do not regenerate. They are replaced by scar tissue that permanently reduces the heart's efficiency. This is exactly why the stent exists. Modern coronary stents are not just metal scaffolding. They are coated with a polymer that contains a drug called a cytostatic agent, which slows cell growth. This matters because when early bare metal stents were implanted, a significant number of patients experienced something called restenosis. The body's healing response sent too many cells to grow over the metal mesh and eventually blocked the opening again. The drug coating solves this. It releases gradually into the surrounding tissue, keeping cell growth controlled enough that the stent stays open while the artery heals around it. This single advancement changed outcomes for hundreds of thousands of patients every year. Now here is the part I need you to pay close attention to. This is where things go wrong after the procedure. When a stent is placed, the body recognizes it as a foreign object. That recognition activates the clotting system. Platelets begin gathering around the metal mesh. If that process is not controlled, a clot can form inside the stent and close it off completely. That is called stent thrombosis. And when it happens, the result is almost always a full heart attack, often more severe than anything the person experienced before. The way modern medicine prevents stent thrombosis is with dual antiplatelet therapy. 2 medications taken together. The first is low-dose aspirin. The second is either clopidogrel or ticagrelor. These 2 drugs work on different platelet pathways. One blocks one clotting mechanism, and the other blocks a separate one. Together, they give the body 2 independent reasons not to form a clot on the stent. Here is why this is so critical. After the stent is implanted, the body gradually grows a new layer of smooth endothelial cells over the metal surface. This process takes roughly 12 months. Once the stent is fully covered by this new cell layer, it is essentially incorporated into the artery wall, and the clotting risk drops dramatically. But until that process is complete, the stent is vulnerable. Skipping even a single dose of antiplatelet medication in the early months after stenting is genuinely dangerous. The clotting system that the drugs have been suppressing rebounds quickly when medication stops. And stent thrombosis can happen within hours, a pattern that comes up in emergency cardiology more often than it should. Someone has a stent placed, feels completely well 8 or 10 weeks later, and quietly stops one of their medications because they ran out or decided it was not that important. They arrive in the emergency room with a massive heart attack, the exact event the stent was supposed to prevent. Do not let this be your story. After 12 months of dual therapy, many patients transition to aspirin alone for long-term maintenance. Some require longer dual therapy depending on their individual risk. That is a conversation with your cardiologist, but the first year is not negotiable. Now here is the other half of the conversation that often gets lost in the relief of surviving a cardiac event. The stent addressed the consequence of atherosclerosis, it did not address the cause. The plaque that blocked your artery formed because of specific ongoing factors. Elevated LDL cholesterol, which contributes directly to plaque buildup, high blood sugar, which damages artery walls and accelerates plaque formation, high blood pressure, which creates mechanical stress on those walls and makes them more vulnerable to injury. Smoking, which directly injures the inner lining of arteries and promotes every stage of atherosclerosis. These factors do not disappear because you have a stent. If they continue, unchecked plaque will keep building in the stented artery around its edges or in other arteries entirely. The risk of needing another procedure is real and measurable. It is not inevitable, but it requires active management. After a coronary stent, the target for LDL cholesterol is more aggressive than for the general population. The goal is typically below 70 mg per deciliter and for higher risk patients below 55. Diet alone rarely achieves this after a cardiac event. Statin medications are typically required, and the evidence supporting their use in this population is extensive. If you have concerns about side effects, those are worth discussing openly with your doctor. But aggressive cholesterol management after a stent is not optional. It is grounded in decades of outcome data. Blood pressure control matters equally. So does blood sugar management, particularly in anyone with diabetes or prediabetes, because elevated glucose accelerates arterial damage in a way no stent can compensate for. And physical activity. This is where fear holds many people back unnecessarily. If you had a stent placed for stable angina or an early cardiac event and your heart function has been evaluated and is reasonable, most people can and should return to regular exercise. Walking is always the right starting point. With proper evaluation and guidance from a cardiologist, many people return to sustained aerobic activity, including running and cycling. Exercise improves endothelial function, it lowers blood pressure, it helps regulate blood sugar, it reduces cardiovascular risk across every measurable marker. It is not just permitted after a stent. In most cases, it is part of the treatment. Work the timeline with your care team, but do not assume a stent means being sedentary. Often, the opposite is true. Here is what living well after a stent actually requires. Take your antiplatelet medications every single day without exception, especially in that first year. Know your cholesterol target and what you are doing to reach it. Keep your blood pressure in a healthy range. Stop smoking if you smoke and get real support to do it. Build physical activity back into your life gradually, and treat every follow-up appointment as an opportunity, not a formality. These appointments are where problems get caught early. A stent is not a sentence. 30 or 40 years ago, a blocked coronary artery often meant death or permanent disability. The main option was open chest bypass surgery with a heart-lung bypass machine. A lengthy, high-risk procedure now reserved only for the most complex cases. Today, most patients are treated through the artery with a catheter without opening the chest at all. What you are carrying in your artery is the result of 4 decades of relentless clinical science. Use it well. The same arterial inflammation and endothelial damage that caused your blockage are connected to broader vascular health throughout your body, including circulation to the brain and kidneys. These are not separate problems. In the next video, I am going to show you the specific daily habits that protect vascular health throughout the entire arterial system and what the research says about reversing endothelial damage after a cardiac event. Subscribe so you do not miss it.